So I think we're about to get started. Everybody's comfortable in their seats and ready to go. So on behalf of the CNS team at the Odette Cancer Center, we'd like to welcome you to our second biannual Michael Rossman Brain Tumor Lectureship. This afternoon is for you and for your caregivers. We've compiled a group of experts to talk to you about different aspects of managing life with a brain tumor. This afternoon will be focused on managing cognitive difficulties as well as stress and anxiety related to living with the side effects of treatment and disease. You'll hear from someone like yourself who's living with a brain cancer and what life has been like for her since she's completed her treatment. We'll also have a timely information session about the role of medical marijuana in the context of cancer care. We hope you find this information to be relevant and useful to you and those who are supporting you. We've packed a lot of information into 2 hours, and at the end of it, we have a panel Q&A, at which time we'll welcome your questions and comments. We'd like to take a moment to thank Michael Rossman's family for their generous gift, which has made this day possible. As you might have guessed, Michael was a patient of ours a few years ago. After his passing, his wife, Catherine, wanted to very much to give back to our team in appreciation for our care. We thank her and her family for that acknowledgement. And we're actually lucky enough to have Michael's daughter, Chelsea, with us, and she'd like to come up and speak a little bit about her dad.
Good afternoon. My name is Chelsea Rossman, and I am Michael's daughter. On March 6, 2014, my father lost his battle with brain cancer. I remember that call like it was yesterday. I was lying in bed, wide awake at 5 a.m. Something inside me knew what was coming, and then the phone rang. It was my mom. Although we knew this day was coming, there's nothing I could have done to prepare for how I would feel. Growing up, I was a daddy's girl to the fullest extent. I was obsessed with my dad, and I couldn't even go a day without a phone call at the minimum. At the end of January 2012, I got a call that would change my life. I was at university, living in a house with my friends. My parents were enjoying early retirement in Florida. I got a call one early Saturday morning from my dad. He said, "Hi, Chelbel, are you alone?" I could tell in his voice that something was wrong. My dad proceeded to tell me that he had been to the doctor and had just been diagnosed with a brain tumor. I remember breaking down in hysterics. A brain tumor? What do you mean? My parents returned home from Florida a couple days later, and that's when it all began. 2 surgeries, 6 weeks of radiation, and countless days of chemo. Throughout this whole journey, my father was very calm. He was unbelievably brave, and what always stuck out to me was that even in the worst of it all, he somehow would always manage to tell us how lucky he was. Lucky? How is this lucky? He would tell us how he was lucky that he was retired. Imagine going through all of this raising young kids while managing treatment. He was lucky because he had kids in their early 20s that understood what needed to be done and could help out where necessary. He was lucky to have the most supportive wife who walked around for 2 years with her head down to make sure that he wouldn't trip on anything as his mobility deteriorated. He was also lucky to be treated by the most incredible, dedicated, and compassionate team here at Sunnybrook. 26 months after being diagnosed, my father lost his battle. Throughout his whole life, my father was extremely generous. He believed in giving back to those who had given to him, and he believed to giving to those in need. Well, here we are. I think today is a perfect example of fulfilling both. Not a day goes by that I don't think about my dad. This past year was an especially hard one for us. In July, my brother got married, and in September, I got married. The loss of my dad was deeply felt, but I know in my heart he was there. An example of this was on my wedding day. I had planned my dream wedding in the backyard of my family home in Orillia. The wedding was Sunday of Labor Day. It literally poured all Saturday night and all Sunday morning, yet somehow the rain stopped at noon, and as I began walking down the aisle at 5 p.m., the clouds parted and it was a full blue sky followed by a rainbow. I can't help but think I had someone looking over me with a massive smile on his face. In closing, I want to express how grateful I am to be here representing my family. I think it's amazing that we are able to have guest speakers come and share, and I truly hope that each one of you in this room is able to take something away from today. For me, I take away hope. Hope that as we continue the sharing of knowledge, we continue to advance treatment and therapy so that less people are affected by this nasty battle. Thank you, and I wish you all the very best.
So thank you, Chelsea, for those wonderful words. We really appreciate you and your family's generosity and that you took the time today to come here to be with us. So I'm going to have Dr. Perry introduce our first speaker, Dr. Wefel. Do you want to come up, James? And sorry. And should I click on them?
Sure.
So that's here.
Yeah, okay. Hi, it's great to see so many familiar faces and welcome. It's great to do this. We tried to fit this into October, October being Brain Tumor Awareness Month, but we didn't get our act together by a couple of days. That's all Claire's fault. So I've known Jeff Wefel for many years, and we've had a number of interactions together over clinical trials, testing new therapies, some common things that we do together for the Society for Neuro-Oncology in the United States. And he's been a tremendous colleague who I've seen grow now into one of the most important and influential neuropsychology physicians. And we're blessed in the field that there are people like Jeff who are dedicated to the problem of brain tumors. And you may not know that sort of around the world in most places, brain tumor centers aren't set up to have neuropsychologists that deal just with brain tumor. You really need to co-opt folks that are working in memory programs, Alzheimer's disease, stroke, and that sort of thing. So Jeff is a tenured associate professor in the Department of Neuro-Oncology and Radiation Oncology. He's the chief of the section of neuropsychology at the University of Texas MD Anderson Cancer Center, which, as many of you know, is one of the most preeminent cancer centers in the world. And go Astros. He has a PhD in clinical psychology from the University of Houston, and did a 2-year fellowship at MD Anderson Cancer Center, where he was eventually appointed as faculty. And his interest, as you'll see from his lecture, and one subsequently later today that many of us will attend as faculty, has to do with all the aspects of cognition and memory and how cancer interacts with that. So not just the obvious and direct effects of a brain lump, a primary brain tumor or a metastatic brain tumor, but also the effects of therapies on brain function, radiation therapy to the brain, chemotherapy, and then beyond that, the effects of systemic cancer. So for those folks that have breast cancer or lymphoma or getting a bone marrow transplant for leukemia, for example, all can have profound neurocognitive effects. And these are the sorts of things that Jeff and his team are working on. He's on the board of the Society for Neuro-Oncology. He's a founder of the International Cognition and Cancer Task Force, which is a relatively new meeting, but it attracts now a global audience of people interested in this topic. So the science of cognition and cancer has really just started to form in the last decade or so. And he's one of the leaders in that area, and that's an area that we're intending on focusing on as we develop our new brain sciences building in the future. So in about 2 years, we should have a new building at the back, from this perspective, at the back of the hospital, as a result of a very generous donation from Mr. Hurwitz and others, which will meld folks from psychiatry, mental health, neurosurgery, neurology. This is where we'll be doing our things with focused ultrasound and taking on all kinds of interesting challenges in cognition and cancer. So Jeff is also part of the steering committee for the National Brain Tumor Society, the Jumpstarting Brain Tumor Development Coalition, and importantly, he's involved with the FDA, so the regulatory body in the United States, on setting clinical trial standards for outcome assessments. And these are the things that are getting critical in our studies. So no longer is it sufficient for us when we're designing clinical trials just to be measuring survival. It's important to advance survival in these diseases, but we're realizing equally important, and in some cases more important, to try to understand what the neurocognitive outcomes of these are. And so he works with the FDA to establish what exact tests and parameters need to be looked at. So without further ado, Jeff.
Well, thank you very much, James, for that introduction. When I came through here, Chelsea told me she might have been a little bit nervous to be up here and talk, but after you get an introduction like that, you get a little humbled and get nervous yourself. The only thing that he left out of that introduction is that I am a recovering soccer player and tore my MCL 3 weeks ago. There comes a point in time we should probably stop doing some of these activities, I'm told, but I just can't bear to give it up. So it's really a delight to be here with you all today and to be a part of this lectureship. By way of show of hands, maybe, could we show who in the audience is a brain tumor patient? And you guys can all look around and notice each other. Yeah, and who's a caregiver or a family member, a friend, a loved one? Yeah, okay, wonderful, wonderful, great. So my charge today is to talk to you a little bit about how we can maintain and maximize our cognitive function in the face of our illness and the treatments that we're going through, and really, you know, life in general. And what you're going to see is those of you who are patients, a lot of these slides and the topics are speaking directly to you, obviously. Those of you who are not patients, there are some principles in here that are as relevant for us maintaining our cognitive function and brain health as anyone else. And so we're all going to take something away from this today. So we always need to talk about who funds our work. So these are some of my funders, include the United States government as well as a number of other societies. And then I consult with a variety of drug companies, usually on topics that James has already introduced you to, clinical trials and clinical trial outcomes. So, you know, it's nice to start with the fact that we have been seeing over the decades improvemements in survival time. We could see this here by decade, essentially, that the number of cancer survivors is gradually...
Your attention, please. Mom, code red, E Delta Wing, second floor, room 26. Your attention, please.
I don't think that's us. Survival time and number of cancer survivors is increasing steadily. And you can see across different primary cancers, testicular cancer here, that the change in survival time has improved dramatically in the last 40 years. There's been some small movement in brain cancers, but not as large as the others, of course. But this has focused our attention on survivorship. So while our survival time is increasing, we also need to make sure that we're improving survivorship, how we live during that time. And what we can see is with the advent of a deeper understanding, is the mouse coming up here so you can see it? Great, okay. With the deeper understanding of molecular characteristics of tumors, we've been able to find subsets of patients who are benefiting significantly from specific therapies. So what you can see here is if you are a patient who has a 1p, 19q co-deleted tumor, and you receive PCV chemotherapy followed by radiation, your survival time was significantly longer, on the order of 14 years, than if you did not have that molecular alteration in the tumor. So there are subsets of patients who are really experiencing long periods of time with their illness, and of course want to maximize their survivorship. Now, even the glioblastoma population more recently has been found in a clinical trial of a device to have extended survival time in, when they get exposed to that therapy. So we're gradually moving that curve of survival time, and how do we now keep up with survivorship? So to start with, let's talk about how our brain's organized. This is a bit of a timeline of our understanding of the brain, right? We were fairly rudimentary at one point in time. And in fact, that in the 18th century, Franz Joseph Gall used to just touch people's skull, feel it for bumps. It's called phrenology. And he would associate personality characteristics with bumps on the skull. And that was the deep understanding that we had of the mind. If you had a bump over here, you were a comedian. If you had a bump over here, you were very sensitive. And that was how we understood brain behavior, if you will, relationships. It was really on the features of your skull. That, of course, improved in the 1900s when several individuals identified patients who had speech difficulties, aphasias, Broca's aphasias and Wernicke's aphasia, and was able to associate that with lesions in the brain in certain areas. And this led to an era of functional localization where we thought very specific areas of the brain had very specific functions. Other areas of the brain did not have anything to do with that function. These were, you might think of it as a neighborhood where each house only had one responsibility. The other house couldn't control speech, it could control memory maybe, and then the third house maybe could do something with decision making, but not with speech or memory. We then had an advent of growth in our neuroimaging that allowed us to appreciate how the brain was wired together, the white matter pathways that connected the brain's surface to each other, and blood flow changes in the brain that occurred when we do thinking tasks or motor tasks. So now we could isolate areas of the brain that were responsible for certain functions, but we could also begin to appreciate, as we've seen now more recently, that our brain is organized into networks and that there's temporally associated firing of neurons and blood flow changes that support certain cognitive processes, and those areas can be geographically distinct. So now we know that house 1 and house 3 both work together for speech. It's not all just in house 1. And this, of course, has complicated our understanding of how the brain's working, but it also explains some of the deficits that we see and some of the recovery from these deficits that we're able to appreciate as well. So while the classic idea that certain areas of the brain, like the frontal lobe, was associated with speech and the parietal lobe with sensation, remain true for the most part, we have this deeper appreciation for this network nature of the brain and how it's being shaped, grown, and working for us. So this is probably the most complex structure in our bodies as well, okay? So there's 100 billion neurons, the thinking cells in the brain, and 60 trillion synapses, the connection between those cells. So that's quite a lot. And when I'm in the United States, I usually say the only thing I know of that's about that same size is the US debt. But that's still less than the number of synapses. So for more global audiences, I like to ask the question of the audience. Anybody shout it out. You know what this is? Anybody? A little more specifically? Galaxy. The Milky Way galaxy, right? It's specifically a picture of the Milky Way. Anybody know how many stars are estimated to be in the Milky Way? 100 to 400 billion stars. So that's interesting, right? Because we have 100 billion neurons. So we effectively have, a Milky Way of neurons in our head, which is pretty extraordinary. So that's the complexity that we're dealing with. Now, many patients do not just have cognitive changes when they have a brain tumor and they're getting treatments. Many experience multiple symptoms. And in fact, one study has found that 3/4 of patients experience 3 or more symptoms associated with their cancer and cancer therapy. And commonly, these are cognitive changes, but additionally, it could be fatigue, sleep disturbance, headaches, motor changes, seizures, mood disturbance, personality change, and sensory changes, of course. These symptoms have been characterized as moderate or severe in about 1/5 of patients and can impact functional independence in profound ways in maybe about 1/4 of patients. And I think this varies across the disease trajectory, of course. Sometimes I think this is probably an underestimate of the severity of difficulties that people have in managing these symptoms. Cognitive dysfunction, though, is quite common in brain tumor patients. And this word blob here that, I don't know if it projects well, but it's outlined in the shape of a brain. What this is showing you are the most common deficits in the largest font size, right? So the most common deficit in a brain tumor patient is a memory difficulty. The next most common is difficulties with executive function, which is our ability to multitask, to reason, problem solve, think divergently, a variety of complex attentional capacities. And then our thinking speed, that we're just not thinking quite as quickly or as sharply as we used to, and it takes a little more time to do things. Cognitive changes are really the largest barrier to returning to work and maintaining functional independence, more so than a motor deficit for most patients. And only approximately 1/3 of patients, when you look at this, I think more broadly, tend to return to competitive employment. And when they do so, they often have to do so with accommodations These might include things like reduced hours, work limitations, or need for increased time off, even if it was just to receive care. And this, of course, is associated with reduced household income, familial difficulties and burdens, and distress, right? So these are complex issues. Cognitive dysfunction is caused by a variety of factors as well. It's important to understand that it's not just the tumor. The tumor, of course, often compromises thinking skills, but unfortunately, the experience of receiving a lot of treatment sometimes can also cloud thinking. But the tumor itself, depending on where it's located, might cause a memory disorder, a speech disorder, a difficulty with visual perception. We all have genetic backgrounds in which these tumors occur, our own genes that will influence whether we have good memories or not as good memories, good executive function or not as good of executive function. So that modulates the impact of the tumor on our brain function. The molecular features of the tumor sometimes influence how fast the tumor grows, and that is related to how well our brain is able to adapt to that growing lesion. And so that will impact the extent of our cognitive difficulties that we experience. Over our lifetimes, we invest in our brain through education, through social interactions, and that investment is a bank account of what we call cognitive or brain reserve. And those cognitive reserve and brain reserve allow us to be more resilient and to tolerate impacts to our brain. So if we have a high amount of cognitive and brain reserve, we tend to have better brain resiliency in the face of brain damage. Then we go through treatments. We get surgery, radiation, chemotherapy. All of these can have untoward effects on cognition. And of course, we have other medical comorbidities, high blood pressure, right, as an example. We may be smokers. We may have medications that have untoward effects on cognition and mood disturbance as well. All of these difficulties can lead to cognitive deficits, and those, of course, can impact life at home, at work, and with our family. Now, how do we mitigate cognitive decline in the face of treatments like radiation and chemotherapy, whose goal really is to kill tumor cells, control tumor growth, but unfortunately we'll have sometimes toxicities, and these are what we call off-target toxicities. So we're intending to use a treatment just to get to the cancer cells, but we also get some normal tissue around it. So radiation maybe is not very specific to just the brain tumor cells. So we've explored a number of approaches in clinical trials, occurring in many different places, to try to risk reduce those treatments. For radiation, for example, we use different planning techniques called intensity modulated radiation therapy that attempts to carve this radiation dose just around the tumors and avoid healthy tissues, or using stereotactic radiosurgery approaches that, again, are very focal. Or if one has to get whole brain radiation therapy, there's been studies that have explored carving out really important areas of the brain so that they don't get exposed to radiation, like the hippocampal region, a so-called hippocampal avoidant whole brain radiation therapy that is done in an effort to preserve memory function. And I'm really a believer in another way to reduce risk is to have cognitive outcomes in clinical trials. If we don't know what the treatments are doing to our thinking skills, we don't know how to pick the best treatment. Many of our treatments end up being somewhat equal on overall survival time. So it'd be nice to know if the overall survival time isn't impacted by treatment A or B, is my brain function impacted differently by treatment A or B? Because I'd like to take the one that's less toxic that gives me the same chance at life. And increasingly, we're developing and exploring molecularly targeted therapies so that hopefully there's more specificity in attacking those tumor cells. And then we've explored this concept of neuroprotection. Is there a way for us to use medicines that are used in other settings, such as Alzheimer's disease, and Mamantine's example of this, to take this medicine before radiation therapy, and maybe it will protect the brain from some of the radiation damage that is so common after that. And in fact, in a study of brain metastasis patients who were getting whole brain radiation therapy, when we gave them Memantine, it increased the amount of time before they exhibited cognitive decline and then was able to maintain their cognition over time. So there was a signal here that this is a potentially efficacious therapeutic approach. I think it's commonly used in brain metastasis patients, at least in the United States and certainly at my center. But really what I think it is a indication that we can develop therapies that can protect the brain, that can enhance cognitive function, and that more investment can be poured into that area faithfully. So that's what we could do on the medical side, but really what we're here to talk about is, well, what can I do today? How do I help myself, and how do my doctors help me today? So let's talk a little bit about this. And the first thing I think to understand is that managing and maintaining our cognitive function really requires a team approach. It's you, the patient, it's your family that's often being asked to come in and be involved, the physicians and nurses, the neuropsychologists, the psychiatrists, the social workers, the occupational, speech, and physical therapists. And that we need to think also about these common comorbidities that challenge all of our lives, but certainly occur even more commonly as a patient. The fatigue, the sleep disturbance, the mood disturbance that we have, none of these are helpful for thinking clearly or thinking well. And then I'm going to share with you some information on cognitive rehabilitation, just mainly general principles, but give you some specific examples about how to manage and cope with memory difficulties, as this is probably the most common cognitive disorder that we encounter in our clinics. And again, by way of show of hands of patients out here, because the caregivers, of course, we all have memory difficulties as well, but patients alone, who here feels like they've had a change in their memory skill that's not as strong as it used to be? Right, so it's, it's the vast majority of the same hands that were up earlier. So the first thing that the physicians and the medical team usually need to help us to do is address any potentially quote-unquote reversible contributors to these cognitive inefficiencies we experience. So they frequently be doing blood work where they're going to look for thyroid abnormalities, electrolyte abnormalities, correctable conditions with replacement therapies or a variety of other approaches. They're also going to survey the other medicines that you're taking. Do some of these potentially have untoward effects on brain function? Do they have things like anticholinergic properties, which is not good for memory function? Are you overly sedated on pain meds, for example? We want to identify mood disturbance, treat that, manage seizures, prevent them if possible, manage the edema in the brain. That also contributes to fuzzy, clouded thinking. And then there's usually a discussion around substance use or abuse. And this is not always an intentional thing on a patient's part. They're not abusing drugs, per se, illicit substances, but may not be taking medications appropriately because of a memory disorder or a planning difficulty. And so that has to be something that we're aware of as well. Is there potentially a risk here that the family is not needs to be called in and asked to manage this a little bit more carefully due to the difficulties that the patient's having? Fatigue, very common, probably the most common symptom in cancer hospitals across cancer types, fatigue. We ultimately seek to identify and treat the underlying correctable medical condition if that's what's causing the fatigue. That would make it simple. Really the leading recommendation for managing fatigue is routine exercise. So, talk with your physicians about how you can safely get physical activity incorporated into your life. That's one of the most effective ways to minimize fatigue. Eating a sensible diet, of course, is another way to help us with energy stores. But sometimes we need to defer to activity scheduling and energy conservation. And that really means, what's the most important thing for me to do today? And how do I orient that, organize that into my day at the time when I have my most energy? And how do I save my energy for the thing I most want to do today? So we just have to start reprioritizing activities sometimes. Then there are efforts to use medicines like stimulants to enhance energy levels. And of course, we want to make sure that we're getting adequate and appropriate sleep. And the recommendation really is for 7 to 9 hours per night, right? So many of us are not probably achieving the recommended number of hours a night, nor probably were we in most of our busy lives these days. It's also important to distinguish between cancer-related fatigue, which is an experience where you wake up tired, you get 10 hours of sleep, you're still tired, nothing seems to give you any restoration of your energy levels, which is fairly unique. And fatigue that's due to poor sleep quality, and that would benefit from sleep training or sleep agents. And depression and anxiety, I think it's really important to understand that this can adversely impact cognition. It also certainly adversely impacts quality of life. I think a common misunderstanding from patients' point of view and from providers' point of view is that we really don't do a great job in interacting over this issue. And this was very clear in a project that was done called the Glioma Outcomes Project, in which brain cancer patients and physicians, about 800, participated in this study for a variety of different reasons, but to include measuring things like depressed mood. And what they did was they had patients fill out questionnaires, the mental health scale, 61 questions, and then ascertained how many of these individuals were depressed. And 93% of the patients filling those out indicated some level of depression and distress. The 3 most sensitive questions still identified 73% of patients indicating that they had distress in their life. Then they said to the doctor who just had the visit with the patient, was that patient distressed or not? They only identified distress in 15% of the patients, right? So we can't see it. It doesn't come in on your label. Patients don't feel comfortable talking about it or bringing it up. Maybe they think it's just going to be a bother, or it's not the right place or time for this, but really there's no better place or time for it. And I encourage this open communication, the sharing. When I talk to my faculty providers, they need to ask. Of course, as neuropsychologists, this is part of what we do, but many other providers don't do this as readily. But this is an important thing for them to be talking to you about. It's an important thing for you to talk to them about. There are ways to manage distress, right? There's counseling, support groups. Oftentimes what we do is we begin to isolate socially, and we're not behaviorally activated. When we do that, the spiral of mood disturbance usually continues down. And of course, there's medications that can improve mood. So this is a very treatable problem, and it's one that adversely impacts how well we can think and our brain function. And it's something that we should be actively pursuing interventions for. So now, here are things that we can all do. I've borrowed this, you should say. I do, of course, note the source, bottom right corner, because we're on film, from the Cleveland Clinic Foundation, because I think it's a beautiful graphic. And they call this the 7 pillars of brain health, or the 6 pillars, I'm sorry, of brain health. And they talk about things that we should all do to enjoy healthy aging. And this is just as appropriate for the caregivers in the room as it is for the patients. So one is we should get moving. Recommendations are for 150 minutes a week of moderate exercise, right? Or 75 minutes of vigorous exercise, as well as strength training twice a week. But 30 minutes a day of walking would be sufficient. And do we think this is going to help the brain? Well, there's some reason that we think it will. Eating smart. So I always say, well, talk to a dietitian. I'm not a nutritionist. You need to speak with your medical team about this. But the general principle for most individuals is that it should be kind of a low-carb Mediterranean diet, avoiding saturated fats, trans fats, added sugars, regular, sensible stuff that we probably all hear about every day these days. We need to control other risks: blood pressure, cholesterol, avoid smoking, moderate alcohol intake. None of these are in excess are good for our brain. Again, rest well. Stay mentally active, remain curious, stay engaged, learn new hobbies, continue living life fully. These are things that are going to help our brain continue to work as well as it can. And stay connected through stimulating conversations. Maybe one of the most cognitively challenging things we do on a daily basis is having that social interaction. It also forms a network of social support, which bolsters against distress and prevents mood disturbance, depression, anxiety. And then we have cognitive rehabilitation as another way to help maximize and maintain cognitive function. So what is that? That is an intervention carried out with a professional, maybe a neuropsychologist. It could be a speech therapist or occupational therapist trained in this, with the goal of reducing the interference of these cognitive difficulties in everyday life. So not necessarily with the goal of restoring memory function, but minimizing the impact it has on your daily life, right? And how do we do this? We do this through things like compensatory strategy training, utilizing preserved skills, for example, to support areas of cognitive weakness. So I've tested patients who have a difficulty remembering words. So someone tells them a story, doesn't really stick. But if they see visual scenes, they can remember that very well. So then you work with them to think about visualizing conversations they're having, and then their ability to remember these conversations is far improved, but through a different modality. There's also a great need for the use of cognitive prostheses these days, and I'm certain this is true for Dr. Perry as well. He's got lots of appointments, and I don't think he keeps them all in his head. I think he probably has a phone, smartphone. I think it's programmed in there, probably by somebody else, and I think it alerts him to where he needs to be next. And oftentimes when we're patients, we say, well, gosh, I can't remember all my appointments. Well, okay, don't try to. Put it all on the phone. Use the smartphone, all right? We need to be using these technologies as cognitive prostheses. If my leg's not working right now, I have this prosthetic thing on it. I have a brace on it. So my legs hurt, I use a prosthetic, of course. If our brain is injured, we should use a prosthetic device as well to supplement it. We may need to talk about environmental modifications. How do we change things in our work or home life to make things a little bit easier? And then psychotherapy and psychoeducation processes are always a part of this rehabilitation, which is really helping us to improve coping and stress management, to help us to identify the situations where the cognitive difficulties always happen, and we experience the frustration and we didn't think ahead to utilize the prosthesis or to prepare for that situation, when if we would have imagined it, anticipated it, maybe we would have had a lot more success in that day or in that activity. These are examples of prostheses. So what I call these are memory prostheses and a memory station, and they can be high-tech, smartphones, pillboxes with alarms. You put these on your keys, and you keep this somewhere centrally. When you misplace your car keys, your house keys, your whatever, dog keys, you push the color-coded button, and it just starts beeping, and then you can chase it around the house. Or they could be low-tech examples, right? The day planner, just a regular non-alarmed pillbox, or like I have on my counter, a bowl where I put my keys in my wallet until my kids move them around on me. But I should know where they are. One place for everything. So what are some specific ways that we often talk with patients about managing memory? The first thing is, in order to remember something, we have to attend to it, right? And oftentimes that part of the information processing change is really where the problem is. We're not as good of listeners. It's harder for us to rein in our mental focus and really attend to what's going on. So we have to apply more effort for this, and it might take more time, and it may also require us to slow down and to really alter that environment. We can't have a lot of noises going on. I can't have the TV on and us have an important conversation anymore. I need to be able to focus on one thing at a time. Then we need to be able to do things that facilitate our learning or our encoding of new information. So when we were learning how to spell words in the 4th grade, everybody probably remembers doing this over and over and over again, just really trying to repeat it and beat it into our heads. Well, it's similar now. Our memory is less efficient. We need to repeat this, give ourselves more exposure to this new information. We may need to process it in multiple modalities. So again, when we were learning words, we said it out loud, we wrote it down, we looked at it and read it back, we covered up certain letters. Again, give yourself all of the access to all those learning techniques again, bring those back to bear on the problem. Using spaced retrieval. We learned the word, and then we said, okay, can I spell it again in 5 seconds after I looked at it? And then, okay, can I do it in a minute? And can I repeat back that word now in 10 minutes, right? That's spaced retrieval. So if there's important information that we're trying to learn, again, repeated exposure, multiple modalities, and stretch out that exercise of trying to recall it later on. So imagery, 3 feet or in a yard, right? This is a lot easier to remember if you make some stupid idea in your head, some stupid visual, and the stupider it is, the crazier it is, the more it sticks, which is pretty remarkable. And this is how everybody got through medical schools. They created all these crazy ideas and mnemonics to remember all the different bones. Nobody actually just rotely memorized them. But this is an example of how to remember how many feet are in a yard. That might be coming helpful when you're in the metric system. How about mnemonics, right? We all remember using those. These are just ways that we're making associations around new information. So how do you remember the Great Lakes, for example, right? The mnemonic Holmes, and each letter stands for one of the Great Lakes. And it's a way to simplify it and make some associations. If I were to say these letters and ask you to recall them all for me, I am IBM, PhD, MTV, CBS. Seems like a lot of them, but if we look at the chunks there, IBM, PhD, MTV, and CBS, now it's a lot easier to remember all those letters. So we're finding things that are related and grouping them together rather than trying to remember all 12 of them independently. It's also helpful if you can use deep encoding strategies, and this means take new information, make it more relevant, oftentimes by relating it to something you already know, or by elaborating on this new piece of information. So we often will do this when someone comes up to us and says, oh yes, my name is, let's see, John Orange. And you say, John Orange, how am I gonna remember that? And you say, oh, well, he's kind of has an orange reflection, and then maybe I should use Don Orange. That would be a little more obvious to everybody. You say, okay, President Trump looks a little orangey. Or we say, oh, he's a big Astros fan, so John Orange, and orange is the Astros color. Now I'm beginning to associate these things, and this is going to be a little bit easier to recall later. When we're reading, we have the classic technique that probably we're all taught in school that is still very relevant now. When we're trying to remember what we're reading, we need to take the time to kind of preview it, survey it, say to ourselves, what is this about? What am I going to learn from this? Develop some questions, read it, go back, see if you can answer those questions for yourself. And the ones that you can't, then review the source documents, the reading material again, keep filling in these gaps, go through that process iteratively until you've acquired the information that you're seeking. So now I want to share with you what I think is, and this is the last thing to share with you, is what I think is maybe an exciting discovery that hopefully will make its way into our clinics and into our lives in the not too distant future. A colleague of mine at MD Anderson, and this is happening in numerous labs around the world, has been exploring the use of mesenchymal stem cells. And these are cells that we all have in our body, but you can also get them from like umbilical cord blood, and then you can develop them, grow them, and they're used in regenerative medicine approaches to try to fix tissues that are damaged and are no longer working. And so in a mouse model of chemobrain, we give these mice cisplatin, this chemotherapy, and that generates a memory disorder that I'll show you. And then what we try to do is see if we can rescue that memory disorder, improve brain function through salvage therapy, rescue therapy with mesenchymal stem cells. And the way that this has been studied is, again, with these mice. So the mice get exposed, this mouse gets exposed to another mouse, it becomes friends. Now, mice like novelty. So when we put a new mouse in there, this one gets ignored. This probably reminds some of us of our past life. And now the mice spends a lot of time here with the new mouse. And we can measure how well that mouse can discriminate the new mouse from the old mouse. And that measure of discriminability is an index of how well they remember the old mouse and spend more of their time with the new mouse. So what you see is if you give these mice saline, this is normal discrimination. If you give them MSCs, it doesn't really change. If you treat them with chemotherapy, all of a sudden they develop a memory disorder. They no longer can discriminate the old from the new one. But if you give them the chemotherapy with the MSCs, their memory is restored, right? So these sorts of approaches are being explored, and many other therapeutic approaches to try to treat these cognitive disorders that we experience after cancer therapies. We've used the same model in a glioblastoma model where we chemo-irradiate the mouse's brain, and we have the same positive effects. And so far, we haven't been able to make tumors in mice grow any quicker, so it also looks like it might be safe. So if we can continue to work through this process and establish how we can do this clinically, we're hoping to be able to translate this approach into a clinical trial as well, so we could hopefully maintain cognitive function, maybe even restore some of it after our treatments. So I think there's reason to be hopeful, and we're eager to move on with this. So these are some online resources. There's a lot of additional cognitive rehabilitation, compensatory strategy approaches at these websites. Some really good information in the Harvard Medical School's Guide to Achieving Optimal Memory. And I thank you for your attention and welcome any questions at the end. Thank you.
So thank you, Dr. Wefel. That was fantastic. It was really a nice balance of science and practical information that I think hopefully everybody found something, as he said, to learn from that. So we're going to switch gears, and we're going to have our one of our patients come and talk to us. Her name is Kristie McMillan. She was suddenly diagnosed with a brain tumor after a seizure when she was 22 years old. She underwent surgery and radiation and a year of chemotherapy, so the same treatment as a lot of people in this room received. She then returned to work as a nurse and is currently completing her Master's of Nursing at the University of Toronto. It's going to have a nurse practitioner. And she'll discuss her struggle to return to normalcy after completing treatment. Welcome, Kristie.
Oh yeah, I'm just pulling up my, I don't remember what to say exactly, so I need my memory aids. Okay, so hi everyone. Thanks for the introduction, Claire. My name is Kristie McMillan, and as Claire said, I was diagnosed with a brain tumor when I was 22 years old. I was diagnosed with an anaplastic oligodendroglioma. Like Claire said, it was pretty sudden. I just had a seizure out of nowhere. I had no symptoms or anything leading up to it. No one was suspicious of anything. There was no hunt for something that was wrong with me. I just collapsed one evening at my gym. So that's a picture of me about a month before I was diagnosed, and it was, obviously I was 22 years old. I thought I was invincible. Learned I was a little bit wrong there. It was an interesting experience for me because I had just graduated nursing, and I was actually working on a unit where we surgically removed brain tumors. So I was quite familiar with the diagnosis that I was given, and I ultimately ended up being treated on the unit that I worked in. This was pretty interesting experience for me. I was walking around my nursing station in my leopard print pajamas with my slippers. I never thought my manager would see me in that outfit. When my surgeon was discussing my surgery with me, I was just sitting on my bed in my pajamas, and I can say being thrown into the position of a respected staff member and then suddenly a patient was quite a 180 to do. My tumor was surgically removed with an awake craniotomy. So some people in the room might have had one of these. It's when they wake you up in the middle of your surgery and they map out the important areas of your brain. I can say that was a little scary when they were waking me up, and I remember thinking, oh my God, I'm dying, and then realizing, no, I was in an operating room, and they ended up having me sing Twinkle, Twinkle, Little Star. And to this day, whenever I go down to the operating room, I'm like, oh, I hope no one was in the room while I was doing that and remembers me. So after having my tumor removed, like Claire said, I had radiation chemotherapy that lasted for about a year. Like other people here, got quite a shock when I learned chemotherapy wasn't covered and was handed a $12,000 bill for my first cycle. I was lucky. It did end up being covered by my healthcare benefits through my work, but that took quite a bit of finagling and involved my dad running downtown to St. Michael's Hospital to pick it up, and quite a challenge for us. So after a year of treatment, I was really lucky. I was able to return to work full time. And I had it was definitely a difficult time for me. I think a lot of us can relate to when you're diagnosed with cancer, everything's on hold. Just everything else in your life stops. And you kind of get into this circle of being sick and an appointment to an appointment to an appointment. So going back to work was really hard. You kind of get to see firsthand how everyone else's life moved on in that year when your life is just at a standstill. So once my treatment was over, I just made the decision that cancer was going to take what it was going to take from me, and I would do my best and not let it take anything else. It was something that I never thought I would face. Well, never really thought about facing specifically in my early 20s. And I definitely pushed myself and to carve out the life that I had planned. So the challenges that we all face post-cancer treatment, you have a lot of difficult moments. Sometimes a lot of people aren't always so understanding. When you're having an issue with your memory or cognition, not everyone knows you had cancer. Not everyone understands why. Maybe you're acting a little funny about something. Feeling behind in life, the hair loss, and you're recovering and you kind of look like you had your head half shaved, or for me it was back when Rihanna had shaved half her head, so it looked like I was trying to look like her, but I wasn't. So that was a little bit of a challenge. And financially, it's a pretty big financial hit. You don't get a ton of money when you're on disability. So I really tried to work on my perspective, just really being fortunate and grateful that I was able to return to work and to come out from my surgery and my treatment on the better side of how things can go. Still been challenging, but I know that I'm really lucky to be doing as well as I am. Coping mechanisms. So I did try using support groups. Some people here can probably relate. Sometimes you go to one and you're like, oh, that was awful. I didn't enjoy that at all. And then sometimes you go to one and it is really great and you really meet people you connect with. Exercise, I always feel like my life is falling apart when I'm not getting some exercise in my day, and that's been really helpful for me. Distraction, I know this might not be the most recommended, but kind of like what was alluded to in the presentation before me, you can't just sit at home all day and think about what happened, kind of forcing yourself to get out there and socialize and try new activities. I've tried playing soccer and volleyball. I'm terrible at all of them. I would tear my MCL first day, but it was something I tried to do, and it does help you kind of feel better about yourself. And also just letting yourself have bad days sometimes. It's hard to always put on that brave face every day, and I always say people really like a cancer survivor that's really hopeful and motivated, but you're not going to be like that every day. That's just not realistic. I think a lot of people go through some grief after they've had cancer. For me, I was kind of forced out of my carefree 20s. I won't go back to being that girl again, and I think a lot of people get pushed out of a life phase maybe earlier than most people do, and just accepting that it is okay to have bad times and kind of think about what you've lost. Also, I know we were just talking about nutrition, but sometimes you just need to eat a bag of chips. Sometimes you do. So since returning to my treatment, I've done some volunteer work with the Brain Tumor Foundation, and I found they've been a really helpful resource. You should check out their website. They have lots of support groups. I actually just presented at a conference for them about a week ago, so I've been talking about myself a lot lately. I'm getting a little sick of myself. They have a run every year in June, which is really nice. You kind of get to see people a little bit outside the hospital support group setting, and it's a little more of a lighthearted atmosphere, which is really nice to see. I work as a Brain Tumor Foundation ambassador at my hospital unit, and it's something I really appreciate. Not every healthcare provider knows kind of the nuances of having a brain tumor. Even I work in a neurosurgical ICU, so it's really nice to be able to provide that kind of support. I think I talked really fast. I think I was a little nervous. So I don't think this took 20 minutes. But I wanted to say thank you to Sunnybrook and thanks to Claire for inviting me to speak here today. And I hope you all enjoyed my presentation.
Thank you, Kristie. That was great. So we're going to have a break. We're going to have some treats. Just as Kristie said, every once in a while you need, I don't think we have chips, we have something good. And we're going to do questions at the end. So hopefully you can use some of Dr. Wefel's strategy to remember your questions, and we'll get to them at the end of our conference. Okay? So I think we have, I'm not sure how much time will last, Tatiana, probably 10 or 15 minutes. And if you go out to where we came in, there'll be a table with some drinks and treats on it. Okay, so I think we're ready to get started. Hope everybody got a nice break and a good snack. So we've got two more topics to cover. Our next topic, we have two speakers who are going to come up, and they're going to talk about the role of medical cannabis in cancer care. So our first presenter is Andrew Jordan. He's currently the regional manager in the Greater Toronto area of the Canadian Cannabis Clinics. He's also a counselor and a medical outreach educator for the organization. He's a graduate of the University of Guelph, and he has a Bachelor of Arts and a minor in marketing. After graduating from university, Andrew pursued a career in direct sales for 2 years. And after witnessing firsthand the benefits of medical cannabis had on his sister's seizures, he decided to get involved with the Canadian Cannabis Clinics. Eager to spread the word about medical cannabis, he started solely as a part-time counselor. After successfully helping patients meet their therapeutic goals through counseling, Andrew was later granted the opportunity to begin doing medical outreach work, which assisted in educating physicians, nurse practitioners, and healthcare advocacy groups. His passions include sports, exercise, acting, teaching, and community work. And our second speaker is Vrishali Suman. She's currently a clinical assistant, counselor, research assistant, and medical outreach educator for the Canadian Cannabis Clinics. She graduated from McMaster University after completing a Bachelor of Science honors, and subsequently pursued her medical career and graduated from Sawa University of Medicine in 2016. She's been very active in the community with volunteer work from a young age, working with the mentally challenged, hearing impaired, and hospitalized patients of all ages. She's also volunteered in various clinical and academic settings. She's helped organize health fairs, published and presented her research report on gastric cancer for the American College of Gastroenterology conference in Hawaii recently, and is actively working on 2 large research projects currently with the University of Toronto and University of Alberta, looking at medical cannabis and its effects on patients. Her long-term goal is to get involved in public health, as her vision is to help prevent and alleviate health concerns for patients and communities. Her passions include singing, dancing, theater, teaching, sports, and playing with her puppy, Artie. So welcome to both of you. I think we're all very interested in hearing what you have to say this afternoon. So come up.
Thank you, Claire. I just want to start by saying it's our privilege and honor to be here and shed some light on cannabis and cancer. There we go. Perfect. So let's go right into it. Health Canada website states, dried marijuana is not an approved drug or medicine in Canada. The government of Canada does not endorse the use of marijuana, but the courts have required reasonable access to a legal source of marijuana when authorized by a healthcare practitioner.
So I'm just going to give you a brief overview of the topics we're going to cover today, so you have a bit of an idea what we're going to talk about. First, I'm going to go right into cannabis and cannabinoids, namely CBD and THC, and explain to you what that is and how that's related to cannabis. Cannabis and cancer research, types of patients who could benefit from medical cannabis, current legislation and how that works factors in with Health Canada as well as the healthcare system, and about us, the Canadian Cannabis Clinics. All right, so the cannabis plant, which I'm sure many of you have been familiar with, especially if you survived through the 60s and 70s, it was very popular back then. Now, the cannabis plant itself is actually known to have over 400 compounds within the plant, of which 60 are unique to cannabis sativa and cannabis indica, which is of the most interest to us medicinally. Now, two in particular that we're looking at with respect to medications are THC, which stands for tetrahydrocannabinol, and CBD, which is cannabidiol. And now, we already have had two, I'm not sure if you're familiar with them, Nabilone and Sativex listed at the bottom there. They have been in the market for quite a while. Now, these are synthetic cannabis pills, which doctors have been prescribing for many years. However, they are synthetic. Now, the medications that I'm going to talk to you about today are the natural ones that are now currently being used through our clinics to be given to patients. Now, THC is known to be a more psychoactive component compared to the CBD, which is one of the many non-psychoactive components that are present in cannabis. And just to give you a brief overview, I mean, many of you might be familiar with what's called the blood-brain barrier. And not all medications affect the brain area so much as the rest of the body and vice versa. So THC, which is known to be a more fat-loving compound, actually likes to go to the brain and act there, which is why that causes more of the psychoactive effects that you really hear people talking about feeling high or stoned. It would be mostly from a THC component compared to the CBD. However, there are many benefits to this that have been studied. Listed here on the slide, some of them include stimulating appetite for patients, reducing vomiting and nausea, especially if it's secondary to chemotherapy use, relieving pain, suppressing muscle spasms. A lot of our PTSD patients, especially those that are veterans, come to us as well for symptom relief from PTSD, and they're given this as well to help them. And sleep aid. So if you have a lot of trouble sleeping or insomnia is an issue, then a lot of patients come to us for that as well. Now, CBD, the cannabidiol, which is the non-psychoactive component, has a variety of uses. Some of them are listed here. It has shown properties to be neuroprotective, reducing inflammation, reducing vomiting and nausea as well. We have a lot of patients that have history of epilepsies and seizures that come to us, especially if they're below 25. A lot of them are actually within the 14-year-old and upwards range. They're suffering from seizures. So very carefully monitored CBD doses are given to them to help with that. And as you can read the rest of it, anxiety is a big one here. And also depression, and also pain relief. So I will talk to you later on about the types of patients that do come to us to benefit off of these medications. So as many of you may already know, there's benign and malignant tumors, malignant of which 80% are gliomas. And this has taken a huge interest in the medical community to study this further. But I would like to tell you that with respect to cannabis, it has been mostly studied, it was called in vivo and in vitro only, with a few pilot studies with humans, but in vivo meaning with animal models and in vitro meaning in laboratories. So to give you an idea of the anatomy behind this, basically we actually discovered that we have a separate system, or the endocannabinoid system, that is present within the body with our own cannabinoid receptors present within the brain as well as peripherally. And this was actually discovered, I believe, in the late 80s to early 90s period. We have CB1 receptors primarily located in the central nervous system, and then we have our CB2 receptors, which are mostly peripherally present in the immune system and the peripheral nerves, vas deferens, etc. There's a variety of mechanisms of action that they use, and it's still being studied to this day. Some of them include stimulating the receptors to inhibit the release of several neurotransmitters or signaling molecules that we use in inflammatory pathways. And actually, there's been certain studies that have been done in animal models to show properties where it can inhibit blood supply to a tumor, for example. So that would be inhibiting angiogenesis. However, because the studies are so limited with respect to cannabis and cancer in terms of for a human population, the best established effects so far from all the studies we've had is for inhibition of chemotherapy-induced nausea and vomiting, as well as we have some phase 3 clinical trials to support appetite stimulation and pain inhibition with cannabis. Cannabis has been proposed for a while now as a potential for having anti-tumoral properties to inhibit the growth as well as the blood supply to the tumor. However, this has never been tested in humans on a large scale, for example, randomized clinical trials. There's a particular study that I found interesting and prominent actually in a lot of research studies conducted by Guzman et al. This was conducted in Germany in 2003. And it's a pilot study that was done with about 9 patients with brain cancer. And I believe the brain cancers ranged from some of them having oligodendrogliomas to astrocytomas. But this study was actually not necessarily done to test for survival as much as it was done to test feasibility, time, the cost of the treatment, the adverse events, and essentially the safety of even giving patients any of THC or CBD. So the results here was that with respect to survival, the study was just not really designed that way to test that, so I can't really tell you that there were any concrete results. However, they were able to determine that it is actually a safe method, and it can be used in patients with brain cancer. So the most common conditions for which cannabis is authorized and therefore for which patients actually come to us, many of them, come to us for pain. Pain is a primary problem for a lot of our patients, especially if they're suffering from fibromyalgia or non-cancer pains. Even a lot of cancer patients come to us for pain. Arthritic and joint pains is another big one. We also have neuropathic disorders for which we treat, so multiple sclerosis, Parkinson's disease, ALS, IBS, Crohn's disease, and seizure disorders, as I already mentioned to you. Nausea and vomiting associated with cancer treatment. So with respect to the nausea and vomiting with cancer, we usually don't recommend it as a preventative or as a primary therapy. Our doctors at our clinic also will tell you that, have you tried all these other therapies with your original physician or your oncologist? Many of you may have heard of ondansetron. You probably have tried that before, and perhaps it wasn't working for a while, then you want to come and try cannabis, that would be an option. Palliative care, insomnia because of pain would be helpful there. And a lot of our patients have been on opioids for a very long time, and they really want to get off of it for side effect reasons. And they want to avoid getting addicted as well. So we help with that. Okay, now I'm just going to pass it over to my colleague Andrew to take over our presentation.
Thank you, Vrishali. So I'm going to just go over the current legislation under the ACMPR. Individuals with a license from Health Canada can grow their own cannabis for personal medical purposes. Now, each licensed producer is very well regulated by Health Canada. With a valid medical document, patients must get their cannabis from a licensed producer. Recreational cannabis continues to be illegal, and storefront dispensaries are also illegal. So we always advise patients to just get their cannabis directly from the licensed producer through mail order. A little overview about our clinics. We have 21 across Ontario, 2 in Alberta and 1 in Vancouver. In the GTA here, we have Whitby, Toronto, Mississauga, Etobicoke, and Markham. Now, all clinics, all patients are, the clinics, it's free to patients with a valid health card. So this is the process of our clinic. You would get a referral from your physician. You'd get assessed by our doctor, get cannabis counseling, and then you get your product from the licensed producer. This is what the referral form would look like. The doctor completes this referral form, returns it to Canadian cannabis clinics. The patients are then contacted for an appointment date at the closest location. When a patient arrives at the clinic, they complete their intake forms, they provide a urine sample, and they meet with our doctor for an assessment. Now, if they're authorized, the patient will meet with the counselor afterwards, and I'm a counselor myself. What we do is we educate the patient the difference between CBD and THC. We assist them in choosing between the different strains available. So there's over 100 strains to choose from. We assist them in choosing the best licensed producer for their needs. We complete the forms for them and we submit them as well. We explain what time of day the strain should be taken. Is it for evening or should it be for the morning? We explain dosing. Some patients use oils and capsules, and we go through that process as well. Guys, I know it's a very, very interesting topic. So here's some links that you can go to if you're very interested here for more detailed info on medical cannabis. So I'm just going to leave this up for just 15 seconds. If you guys want to take a photo and go to these links for more info, that'll be there for just a few seconds. I'm going to wait till the last phone gets put down. Okay. So just a brief overview of what we discussed today, and of course you guys can ask any questions you'd like at the end during our Q&A. Cannabis and cannabinoids, cannabis and cancer research, cannabis and who would benefit from it, and the current legislation right now, and the Canadian Cannabis Clinic's background.
Okay, so just to conclude our presentation, it's a little bit short, but hopefully we'll be able to discuss a little bit more during the Q&A. But medical cannabis is here to stay, as you already know, with what the Canadian government is going to be going through with for next year. And it has been used by people for many centuries. It is helping people return to function and improving quality of life for so many. And if you take anything away from today's workshop or presentation rather, let it be that cannabis is medicine. Okay. I'd like to just thank Dr. Barry Weisglass and Dr. Jonas Vandersman, who actually were doctors at our clinic that were working there, to give us some information on this. And thank you so much for your time.
Thank you, Andrew and Vrishali. That was a nice overview, and I'm sure you're going to get lots of questions later. So we're going to go on to our final speaker, who is one of our colleagues here, Ben Diplock. He's a research assistant at Sunnybrook Research Institute and a clinical psychology graduate student at York University. His research focuses on wellness promotion and integration of mindfulness-based interventions into clinical contexts. Ben is currently part of a research project that's funded by the Brain Tumor Foundation of Canada and investigating the impact of a mindfulness-based therapy on mood and quality of life in brain tumor survivors. And some of you in the audience may actually be part of the study. So thanks, Ben. Come on up.
All right. Thank you very much, Claire. And thanks everyone here for being here, and also for everyone who was responsible for having me up on stage. Appreciate that. So as Claire mentioned, I'm going to be talking about a study that we currently have going on here at Sunnybrook. So it's called Mindfulness-Based Therapy for Brain Tumor Survivors. As Claire also said, my name is Ben Diplock. I'm a clinical researcher here. And this is kind of a project that's been of very big interest to me and also to my colleagues who are also a part of the study who couldn't be here today, but wanted to send their regards. So that's Dr. Stephen Selchin and Dr. Janet Ellis, who are both psychiatrists at Sunnybrook and who both have interests in the oncology population as well as mindfulness as an intervention. So when we were looking through the research, we were talking about different studies that we possibly could do. And I've had an interest in mindfulness, and as a brain tumor survivor myself, I also had an interest in the brain tumor survivorship population. And so I started looking into some of the literature, and it suggested to me that many of the brain tumor survivors in the studies that we looked at have long-term difficulties, but limited resources are available. There was one study suggesting that out of the resources available, 75% of the resources were limited had limited to no information about survivorship. And for me, that was kind of really important to dig a bit deeper, and it showed a bit of a gap in the literature. And then also the majority of survivors are interested and could benefit from learning effective methods to improve the day-to-day. So while that support wasn't there, there's a lot of interest, right? So some of you folks may feel that. There's a lot of interest in improving some of the things in your life, but there's not the resources available. So that was another gap as well. And a lot of the difficulties experienced by brain tumor survivors go untreated or unnoticed by physicians or by people around them, or maybe even by the individual themselves. And that results in reduced wellness and increased survivor and caregiver stress, which can just add to a bit of a downward spiral. So all of that information really led us to go, this is something of interest to look into and try to figure out how we're going to do that. This is a slide that Dr. Ellis had really wanted to put in, and I think it's a good illustration of a lot of the our lives are extremely complex, and it's looking at a lot of the different facets in life that can cause improvements, and that also can cause us to have difficulties. Anyone in life can experience this, and it either leads to adaptation or distress. And so that could be depression or anxiety or chronic stress. And so we thought this was really relevant to our population. So you can see all of those different factors up there. And I think this also be available, these slides will be available online afterwards as well, if you want to look in deeper. And then also we looked at the prevalence of distress in cancer diagnoses. And if you see the red block at the end and the lighter pink blocks, when we look at brain cancer, it's pretty much in line with all the different types of cancers, right? And it's higher, lung cancer and brain cancer being one of the higher in terms of positive cases of depression or anxiety in terms of percentage. So that shows, once again, this is really an area that could benefit from further research and further understanding. So also a study that was done looked at the consequences of untreated depression. So if an individual goes through their life knowing there's something different and they're having difficulty after their experience with cancer, with a brain tumor, but they don't know what's going on, decision-making is something that's really important. So having the physician being able to make those early decision-making calls, which may be difficult to flush out. But, there's also difficulties with experienced by survivorship with early discontinuation or delayed recovery. So discontinuation of drugs, discontinuation of treatment, prolonged hospital stays. These things can all kind of cascade together, or they might happen in tandem or not in tandem. And then physical symptoms or reduced immune systems, disability, return to work, substance use. Some of these things might sound familiar. Maybe all of them do, maybe none of them do, but these are really important factors to consider too when we're considering untreated depression and anxiety to a certain extent. So we're thinking, what determines quality of life in people in general, and something that we can then shift over to brain tumor survivors. So really looking at the idea of some people experience loss of independence for a certain amount of time or for an unknown amount of time. Do they have the supports? Do they have professional supports here at the hospital? Do they have the family supports? Do they have the supports from friends? Cognitive impairments can be a difficulty, right out of treatment, or it can be something that's more long-term. And then also emotional distress, which is kind of more the area that we kind of focused in on as well as physical burden and neurological disability and fatigue, which can be major components. So we found that, I think this was actually on BTFC's website, and thank you very much. I didn't acknowledge BTFC, but for funding this study, they've been fantastic throughout the process, so we really appreciate that. So there's 55,000 brain tumor survivors in Canada alone. That's a lot of people who may or may not be experiencing emotional distress. And it got us thinking, what do we really know to be an effective long-term resource that improve quality of life? Once again, look in the literature, and there's not as many resources as we'd expect. So what's a potential option? And would it be helpful to brain tumor survivors? Would it be something that would be relevant to brain tumor survivors? So mindfulness came to mind. A little corny play on words, but so thought about mindfulness as a potential option. And I know this is really is it okay? I think it showed up a little weird on there, but anyways, I know it's a really dynamic diagram. We're trying to keep it simple for you guys. But that blue circle is, and don't worry, it's only going to get more complex as we go. That blue circle is difficulties that we have in our life. Life can be difficult at times. There are things that happen and that we don't necessarily have as much control over. Life events occur. We can't control everything, even if we try our best. But they occur. And then there's this nice little red circle around. And this is kind of more what we want to focus on with mindfulness. And I'll explain a bit of a definition behind that as well. Really looking at the distress that we bring about when these events occur. So something happens in the family, you get in an argument with one of your spouse or with a sibling or with a friend or a coworker, and then you tell someone else about it, or then you get really upset, or then someone cuts you off when you're in traffic, and then you get more upset because of that. And then we just create a lot more frustration in our own lives about something that maybe was just an argument now it becomes a huge issue. And so and a lot of times those are things that are all in our head, right? And they're as real as anything else. But they're things that maybe if we take a second to cool down, take a second to breathe and think about it, might be something that we have a bit of control over in our life. And so we really want to target that red circle. It doesn't take away difficulties in life, because those are always going to be there, but it might reduce some of the difficulties to make life a bit more easy to function in. And so that's another, just to say goodbye, there's the blue circle again. So what is mindfulness? And now there's a lot of different terms, and there's within the field, there's different arguments, and mindfulness has a lot of Buddhist roots. The secular form, Western form of mindfulness that we are considering today has Buddhist roots. And so there's differing definitions, but for the purposes of today, it's really looking at awareness that emerges from paying attention. So whether that's paying attention to the breath, paying attention to the body, thoughts, emotions, sensations, just things that are going on right now in the moment. And paying attention to that on purpose and in the present moment, as I said, and non-judgmentally too. So a lot of times thoughts may have a certain emotional valence to them. So trying to think about it non-judgmentally. To things as they are, so in the current moment. And that was John Kabat-Zinn, who's a big name within the area of mindfulness research here in the West. So the study of mindfulness-based therapy for brain tumor survivors really came out of this knowledge and understanding. Something that's been really interesting in the last little bit has been seeing some of the individuals who are part of the group and how I think it really relates to a lot of their experiences in their life, not necessarily changing things, but realizing how things are in the current moment and what people can do to work with those situations rather than trying to change it. It's not a change-based therapy. So our question was, and I have 8 weeks, it's actually being reduced now to 5 weeks. So this is a good lesson in looking over your slides before you send them. So it's being reduced to a 5-week program that we actually do here at Sunnybrook for other populations. And we want to see if this is something that's relevant, helpful, and supportive to brain tumor survivorship in terms of improving quality of life, improving mental well-being, reducing depressive symptoms, and reducing not the up arrow but the down arrow on perceived stress. We don't want to make people more stressed out. That wouldn't be cool. And we're doing that, as Claire had said. I get the wonderful opportunity of working with the folks over at Odette in terms of recruiting patients, and they've been absolutely lovely. So we're doing that over there. We've been doing it for quite a while now, and as a relatively new researcher, it's, some people may have that experience, or other people who have been part of the studies, any studies in the past. It takes a while to get people on board, but it's been a really great process. We've had a lot of support, and we're still chugging through. So we're really looking for individuals within the clinic who hasn't had treatment within the last 6 months. So they've been clear for the last 6 months, at least, or more. There's limited cognitive difficulties within their symptoms, and also they're experiencing low mood, something that we could tap into. Something that we've also found really interesting is maybe looking in the future at anxiety as well, because mindfulness has been shown to be helpful with anxiety too. So that could be a future study or consideration or resource as well. So I think that's it, and we'll leave the questions till afterwards. But thank you guys so much for your time, and if you have any more questions, they'll be up here. Thanks.
Thanks, Ben. That was a great overview of your study and how you guys got to where you are at this point. So now I want to invite all of the lecturers to come up and take a seat, and we'll do a Q&A, which Dr. Perry is going to moderate for us.
Well, I hope you enjoyed that. We certainly will welcome any feedback that you have on the format and the speakers. It was intentionally different than the one that we did 2 years ago, which was a little more therapeutically based and scientifically based. And I think we might have these sorts of alternating formats. So Q&A, this is your time to ask any questions. There'll be it'll be very non-judgmental from the front. There is such a thing as a stupid question, but we won't tell you if you ask one. And you can ask pretty much anything you like, and I'll direct it to the appropriate people. So if there's anyone that wants to lead off with any thoughts or experiences that they have, you can be, as indiscreet as you like, or you can tell us about what your situation is, and we'll see what we can answer. Ali?
That's great. Quick background on me. Dr. Perry has been my doctor for 15 years. I'm been tackling a pesky GBM that just seems to love me, keeps on coming back. So 15 years out, and a lot of what you said resonated with me. A question though, which is general and not to anybody in specific, then I have one for Ben. Outside of medical cannabis, what are your thoughts in general on alternative medicines and treatments? Are they helpful or a hindrance?
Outside of medical cannabis, do you have any alternative medicines that you come across or discussed with anyone before?
Yeah, I have a deep phobia of needles. After 15 years, I've been poked and prodded and pinched and cut and God knows what else. So I had one naturopathic doctor recommend IVC and IVB.
Did they explain to you what that was? Like, in terms of like how, I'm sorry, I'm not familiar with IVC and IVB.
Well, by IV, you get like a full liter of concentrated vitamin C or vitamin B.
So I'm not that knowledgeable on naturopathic medications in general, so I don't have a perfect answer for you. But I can tell you that with respect to what I know from the research that's been done on like naturopathic medications and alternative medications, I think that there's still research that is being conducted on these, and I don't recall coming across any substantial evidence to say this will work or not. I think right now alternative medications are in that zone where it's very like it depends on the patient. I've had a couple of patients come to me, for example, let's say you're on a cholesterol pill, right? And there was a patient that came to my clinic once, not this clinic, when I was in medical school, and they were on statins, for example. A lot of you might have heard of statins for cholesterol before, and they were saying that they experienced sort of memory loss from that, and which is not a very common side effect at all. So they were recommended red yeast rice, which is actually from another alternative medication practitioner, and their cholesterol was normal levels. However, if you look at the research on that, then it's not really all that substantial. So from my personal experience, I can't speak for the medical community necessarily, but from my personal experience, I can say that alternative medicines is a very it depends kind of answer. It would be really a discussion with your physician and probably with your naturopath to figure out what works best, and if you're using it as a alternative or if you're using it preventative. So I think that would be my answer for you. Thank you.
Now to Ben, you talked a lot about the patient. What about the primary caregivers? Are you looking at that group as well? I know they go through, just because my wife is my primary caregiver, they go through a lot of stress. Is there any thought about holding training sessions?
Absolutely. So I think that's a great question. It's something that's actually come up in our recruitment. So when we've been going into the clinics and talking with family members and loved ones, that's something that's been consistent, where the caregiver will say, or the spouse, the family member will say, do you have anything for me? And, along with the question of, I'm experiencing anxiety, but not depression, do you have anything for me? These are really important areas that we're starting to see there's also a need for. We don't have anything targeted specifically at any training sessions or opportunities for caregivers, but I would be happy to chat with you afterwards about different resources that are online and different options that are available in terms of mindfulness-based resources. Thank you. Great question.
I'm going to elaborate on that a little bit. So this is a really big area of study right now in the brain tumor community. I think there's a growing appreciation of caregiver distress and caregiver burden, and we haven't been great about dealing with and managing that. There have been a number of studies recently that are going to be reported out the next year about some intervention programs and their success or failure to help in this situation. But you can also go to online resources like the American Brain Tumor Association, the National Brain Tumor Society, you get them through Google, and they have caregiver resources there. And a lot of this, in my experience, has been that caregivers just oftentimes don't know what to expect at different stages or different phases of the disease, or how to manage certain symptoms, or when you need to call, when you need to do something. UCSF, the University of California, San Francisco, has a wonderful pamphlet. It's like a 30, 40-page document chronicling a caregiver program that they've established and giving a lot of helpful suggestions. So I think there's some what we call bibliotherapy that can be accessed on the internet. But increasingly, I think you'll see this is also an area of clinical attention and many cases of use.
So I'll add to that just briefly. We're always learning, and as long as you've been in this business, you're always learning new things. And when Chris Mueller joined our team with a lot of background in palliative care and a really unique ability to communicate with patients. And what I've learned is the caregivers are a little afraid to ask, but what you really want to know is, what's this going to look like? What's this going to look like? Right? For my loved one, what's this going to look like for me? Well, that's a very hard question to ask, and it's obviously changes with time, but it always needs to be refreshed. So never be afraid to ask our team about that, because I just sort of learned that that's a very important question for me to say. Do you want to hear more about what this is going to look like? I never really used that term before, but it seems to really resonate with folks. Yep.
Sam Dodd. Just had brain cancer since 2015 or 13, and I also have Dr. Ironside over there. Good people. I was just going to ask the doctor, and I hope I say this right, Wefel. Did I say it right?
Yep.
Oh yeah, my mom would know what you're saying.
Sorry. I just want to know, I guess part of it is I have troubles with writing, and also right now I'm not too bad with my words and stuff, but sometimes I don't. But I get my wife here to help me out, and that way, you know, I can just sit back and, you know, she can help. But I'm wondering if I keep going almost like I'm like a exercise type of thing, can you really bring that back?
Sure. So usually what I advise patients to do in the situation when they find they have word finding difficulties, and similarly as you try to express yourself in written form, it may be hard to recall the concepts and organize them for you, is that you continue to use everyday approaches. You circumlocute, right? So you talk around, you're looking for that quarter word that you just can't find, but you know what you want to say, and you can talk your way around it so that everybody would understand what you want to say. And I encourage people to do that because that usually decreases their frustration. As soon as you start getting frustrated about retrieving that word, or you get anxious about it, the ability to retrieve that word goes way down, right? And then it's only later when you settle down a little bit that it tends to come back to you. Now, can you potentially restore that capacity through some sort of therapeutic approach? So speech pathologists have been studying this in stroke patients largely, generalizing a therapy that's used for movement difficulties called constraint-induced movement therapy, where you do not allow the normal arm to do the work of the arm that has the trouble. You constrain this one and make that one have to practice movement. And you can improve some motor capacities that way. So then they were interested in asking, we do the same thing with language. We do constraint-induced language therapy and see if we could restore some of the speech properties. And that research is not finished. We don't know if we'll work it out. And I'm not aware of anyone trying that in the brain tumor setting. So for now, my recommendation to most patients is to allow themselves to use compensatory communication approaches rather than forcing themselves into a frustrating situation that I simply don't know if it's going to be effective.
Is there one?
Well, my question is for Kristie. So Kristie, I just wanted to know, when you went back to work, when you decided that you were going to go back to work and try to pick up your life plans where you left off, did you go back full-time, part-time? Any suggestions of what to do when that happened?
So I went back initially as modified, it was called, so I had some reduced duties. So I started off as part-time and then I gradually worked my way to full-time over the course of about 2 months. But I would definitely, personally, I would recommend starting off at part-time. I was really surprised at my fatigue levels before I started going back to work. I was convinced I was fine and I wasn't going to have any fatigue or anything, and I kind of learned the hard way that work takes a lot out of you. So if I had to give a recommendation, I'd say kind of start low and go slow with your work hours.
And it was emotionally and physically stressful? Both?
It was more just fatigue that I found was the big issue, just being exhausted even after I do 12-hour shifts and they started me off with like 4 hours, and just I would nap for like 3 hours after one of those, so that was a big challenge.
Kristie, I was going to ask you if you could talk a little bit about what it was like to go back with the modified schedule and how the people that you worked with reacted to that, and if that was a problem or people were supportive.
Most people were supportive. My story kind of went like wildfire, I think, to my unit, since it was an interesting. Having like a staff member treated on the floor, most people knew what happened, but I know a lot of people kind of think you're being treated like cushy, or you're getting a lot of benefits. And I know a lot of people that do struggle with that when they go back to work modified, and I faced it a couple times. Not everyone understands that when the chemo's over, the treatment isn't done, you're not recovered after your last dose of chemo. It's going to take a couple months, it's going to take some time, and the public doesn't always understand that. And I don't know how you would cope with that. Pulling people aside and talking to them can help sometimes, but it's kind of an overall mindset that the public has. I think even outside of cancer, if you're not bald and you don't look sick, they think the cancer's done with it, moved on.
Anyone else? There's one. Oh yeah, great, thanks.
For Dr. Jeffrey Wefel. I just want to know, so as a caregiver and as a parent, like when your child's behavior changes and their personality changes, but they don't recognize that, like they're not aware of. So then your dynamic changes of your whole family and your parenting style and everything. But how do you get through to the patient that they're different? Like without getting into arguments and
Yeah, so this is, I think, one of the most difficult things for us to manage through the disease course, and this is your son next to you as well. Yeah.
He's much better, but I wish I'd known that because nobody gives you a course. You don't get a one-on-one. You don't get a 101 in cancer, brain cancer, when this happens.
Sure.
And of course, everything's heightened. So initially, he was a completely different person. Like he's much, much better now. But I'm just saying that I would like to help other parents.
Absolutely. Yeah, and one of the complexities too, if we're dealing across many different age groups, are what are normal changes, normal developmental changes, personality changes, what are normal responses to stressful situations, and what are not normal. And part of that is a process that one needs to go through and explore, often with, it's helpful to do this with mental health counselors, right, psychologists, neuropsychologists, neurologists, to help you understand if this is normal or not. But then a general approach to this in terms of how do I get the person to believe what I'm saying? Well, how would you get any, I'm just going to use this because I think it's most of the example, how would you get any 17-year-old to believe what you're thinking as a parent, right? That's a monumental task to begin with, right? Maybe that should be the goal. So oftentimes these personality changes result in some sort of disruptive behavior that's usually frustrating and that one's trying to correct. And the general principle is to, rather than concentrate on all the examples of the personality change and disruptive behavior, is to rather look for all the positive examples of pro-social behavior and reward those. Spend time rewarding and encouraging all the positive examples of behavior. And then that often generalizes and feeds itself into more of those positive pro-social behaviors because they're associated with a consequence, an outcome that everybody enjoys, the individual included, rather than constantly engaging in a battle about change, you're doing this, no, I'm not, right? That may not have as much traction. I think this is one of the biggest challenges. And of course, depending on where the brain tumor is, there are regions of the brain that control our emotional reactivity, our perception of self, and it could be, these can be neurologic deficits that are not remediable in the common world. We could just learn this new thing, right? And they're just permanent changes. So I'm glad to hear it doesn't sound like that was the case here. Yeah, wonderful. Yeah.
If I can say anything, in between my diagnosis and my surgery, I definitely was not acting by myself. I was really confused, and I did have a little bit of a personality change, and I can say I knew something was wrong with me, and I knew everyone else knew something was wrong with me, but I didn't know how to communicate that I knew something was wrong with me, and that was getting me really frustrated. And unfortunately, I think it was just patience on the part of my friends and family dealing with me, because I was getting pretty frustrated. Trying to explain that I knew I was different, but not being able to was really hard.
Should we, do you have closing comments? Or?
Well, I was asked one more question
Okay,
to
yeah,
Andrew
good.
Vrishali. So just about, we have a lot of patients who ask to receive medical cannabis, and there's not always an indication. They'll just say, I want a referral, and we do refer them to clinics. But so how do you approach that when a patient comes to you and they don't have really a specific complaint that they're seeking cannabis for, but they're just saying, well, I've got cancer. And you did allude to some of the study about brain tumors, and we do get a lot of that in our clinic, patients saying, I want to use it to help treat my cancer. And so how do you approach that in your counseling and your recommendations?
Right, so we do end up encountering that quite a bit. And the thing is, we're working, so our clinic is primarily, we have a lot of family physicians and a couple of internists that are working as well. So when they do encounter that, we have to remind them that, we do have studies showing this, but it's not currently being used as an anti-tumor drug. And a lot of the cancer patients are already receiving chemotherapy or radiation therapy, and so we primarily would see them for anything that, then we would ask them further, like about we would take their history and of course do a physical exam and ask them further, like, do you experience insomnia? Do you have any sort of distress? Are you experiencing depression? Are you, things like that. And so, well, to be honest, it's not everybody's eligible to actually get the medical cannabis. So if the doctor feels that the patient, has not tried enough of the conventional therapies, or this is of course usually not cancer patients, but if the cancer patients are coming in and they feel that they are being adequately monitored, usually we are already in conversation with their physicians by the time they do come in or soon after that. So that's kind of how we go about explaining that to them. And there's a couple things I did not mention in the presentation, and I could actually maybe elaborate just at this moment here as well. With respect to talking about cannabis as a medicine, I think most of us are very familiar with just seeing it as people smoking the weed right up on the streets. However, medical cannabis that's given out now is, I think I already mentioned to you, there were synthetic pills that have been out in the market for a while now. But also the ones that we actually give are either the dry flower, or we give it in the form of oil. Now, the dry flower is, we don't recommend smoking. Smoking, we already know, carcinogens, etc., not good. We usually might recommend something called vaping. Okay, so it's basically like steaming the flower, so you can inhale that. And that is usually used for acute conditions. So somebody's having acute pain that sort of comes and goes and they need it to go away right away. Then we recommend just take, vape that, or pretty much inhaling the steam, and then hopefully within 15 minutes it'll address the pain issue. Now, with respect to the oils, they're usually taken with a dropper. You put it under the tongue, or you put in some orange juice and you take it in that way. And because when you ingest something, under the tongue actually is sublingually, so it would go through there. But if you were to swallow it via orange juice, because it would go then through your liver, and then into your bloodstream after that, it would take a little while to have an effect. So that's usually used for maintenance therapy. So with respect to your question, I hope I answered that for the most part. And then with cancer patients, a lot of them come primarily for insomnia issues and also depression and also pain. If they have any pain issues going on, that's kind of where we step in. So we have to remind them of that when they come in.
Okay, well, I just personally want to thank our panelists for coming. It was a really interesting afternoon. I've learned some things for sure. Those were great talks. I especially want to thank all of our patients and caregivers for supporting this, Claire and committee for organizing this so well, and last but not least, Chelsea on behalf of the Rossman family, without whom we couldn't have this, and we'll have it for many more years to come. And I don't know if Claire had some closing remarks.
I also want to thank our panel. I think it was really a very varied and interesting conversation this afternoon, and I hope our patients enjoyed it too. I really appreciate everyone coming out. I know it's not easy to get here, especially when you're already coming here for appointments and MRIs, so that you made an extra effort is really very nice of you and very much appreciated. Also to Chelsea, thank you to you and your family for supporting us. And so we hope that this was helpful. There is an evaluation form, and it would be great if you could fill it out and let us know how you thought things went today. It is helpful for me because I did look at them from 2 years ago, and that's what helped kind of mold our panel today. So I'd really appreciate it if you could do that. And I think you all should have received a parking voucher from Tatiana, but if you didn't, right there. I want to make sure that you don't have to pay for parking today. Thank you very much.